2020 COVID-19 clinical rounds on critical care, diabetes, and COVID-19. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations and societies who have collaborated on these rounds. These rounds are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. This Thursday, November 5th, will be emergency department rounds focused on physician suicide during the pandemic. Stay tuned for announcements for next week's rounds. It is self-evident that our nation's medical response challenges continue to change every day. We will continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. On another note, we started these rounds way back in March 24th, and many of the participants on these rounds began with us back in March 24th, and some have remained. One of the things that I think is really important as many areas of the country are being faced with the surge for the very first time, that participants from the past can help benefit those who are being faced with it right now, and really appreciate your participation as it continues to unfold. I'm going to ask Dr. Bruce Struminger to now go over some logistics.
Thank you, Rick, and welcome everyone. Happy Election Day, and really appreciate people taking time out to join us today. Hopefully you've either already voted or you're going to go out and vote later. I'm just going to go over a couple of our regular logistic items and housekeeping items. We love hearing from everybody. We love your questions. We love your comments. So please share your questions and comments related to today's topic on COVID-19 and diabetes in the Q&A feature down at the bottom of the Zoom toolbar. If you have any IT or logistic issues, please put those in the chat function, also along the Zoom toolbar to the left. We'll be monitoring both of those. We are recording today's session, and your attendance is consent to be recorded. Thank you for that. The presentation today will be shared with everyone. Hopefully it was also shared in a link on the announcement that went out, but we'll be sharing it later with a link to the recording on our website, and Amanda will be sharing that with you through the chat, and the recording and the PowerPoint should be available within a day or two. We are offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. We really encourage everyone to take advantage of that CPD opportunity, and we really appreciate the feedback you give us about how we're doing with implementing these rounds. So even if you don't want the CME or don't need it, we'd appreciate your feedback. So if you can, take 2 or 3 minutes at the end, and you have up till 48 hours to complete the survey, and you'll get an instant electronic CME certificate. There also should be a link to that in the announcement that went out today. Just a reminder that these learning sessions are focused on improving patient care and health systems and supporting clinicians. So please keep them apolitical and non-commercial. Thank you for that. And just a word about data use. The data that you share with us when you register, when you answer the polling questions, we take data stewardship very seriously. We keep your data carefully guarded, and when we share data with Rick and Asper, it's all de-identified. Most of it's de-identified when it comes to us, and whatever we share with Rick that isn't is de-identified when we share it. As Rick mentioned, NETEC, the National Emerging Special Pathogen Training and Education Center, is a partner in these clinical rounds. They've been running a wonderful webinar series that complements this series in many respects. They have a session tomorrow on COVID-19 and acute renal failure, and on Friday on care transitions to home health. And they have an archive of all the webinars they've done since March. So we encourage you to check that out. Also, the AAMC is a partner in this initiative, and they've been building a wonderful clinical repository, clinical guidance repository, which they keep up to date on a weekly basis. So we recommend that you take a look and use that. It's a terrific resource. Rick, back to you for the crowdsourcing question.
Thanks. You've already seen the crowdsourcing question already, but before I actually say that question, I want to double down on something that Dr. Struminger mentioned, the apolitical nature of the rounds. I just want to thank all the participants, not just for this rounds, but the 35,000 some participants we've had since the beginning of the rounds on staying very, very focused on the patient and clinical operations. It's been extraordinarily gratifying. Before I introduce, okay, crowdsourcing question. What has been your experience with assessment and management of diabetes and COVID-19? It's fascinating. The whole issue of diabetes came to my attention related to COVID-19 by my colleague on the Healthcare Resilience Task Force, Dr. Till Jolly, who actually joined us here for the rounds. Till, you mind introducing yourself? And then Marco Singh.
Yeah, good afternoon or good morning to you. Till Jolly here with the Resilience Work Group. Looking forward to it.
Thanks. Marco.
Yeah, thanks very much, everybody. Rick, well, this is a great presentation. Looking forward to it. Dave Marcosi from University of Maryland.
Hey, thank you very much, Marco. Appreciate it. Appreciate you being on. With that, I'm going to go ahead and introduce our speaker. It's really an honor. I reached out to her and she was gracious enough to accept this one while she's got very, very busy clinic schedule. She's a busy lady, just like everybody's busy these days. But let me turn this over now to Angela Drinsick. Dr. Drinsick is professor of medicine at the University of Nebraska Medical Center and the medical director for their Diabetes and Endocrinology Center. So Angela, please, I'll turn this now over to you.
Okay, you guys can hear me well, right? Cool.
Yeah, yes.
Thank you so much for inviting me for this session. Let's see, I'm gonna slideshow, play from the start. Okay, do you see everything well? So,
looks great.
Thank you for inviting me. Thanks to everybody for coming for this talk. And if somebody told me in March that this topic will be still interesting to anybody, I would not have believed it. I think all of us thought that it'll be over. And unfortunately in Nebraska, like in many places, things are sort of heating up and it's really kind of worrisome. So I'm going to try to do 10 questions in 10 minutes. 11, 12, I don't know, don't hold me to it. So I'm really going to talk about just some sort of a hot topic things about, what's the risk with diabetes, why this may be, and just talk a little bit about management of diabetes in a hospital setting. So the first question is, does a person with diabetes in the community, are they at higher risk for actually catching quote unquote coronavirus and getting COVID? And because it's been well known that diabetes is for sure increased risk for infections, especially upper respiratory, and that's been shown with SARS and MERS and H1N1. However, it seems to be that diabetes does not increase the risk for getting COVID-19. The other totally different issue is that when people do get it, then it is more severe. The other reassuring piece of news that was just published in Diabetes Care recently looked at the rate of hospitalizations of people with type 1 with COVID, and there was really no increased risk for hospitalization. And this study was done in Belgium on more than 2,000 patients, and the rate of hospitalization was just the same. Now, a separate issue is when patients, get hospitalized for COVID, does diabetes convey a worse prognosis? And the answer to that question is absolutely yes. Multiple studies were done looking at outcomes from ICU admission to severe disease to mortality, and they all have shown increased risk for complications anywhere 2 to 3-fold. And unfortunately, in a recent publication by Lancet, it looked at mortality in patients with type 1 diabetes, type 2 diabetes, and overall population from COVID-19, and clearly the rates are increased. So then the next logical question is, why would that be? Why is diabetes a risk factor for adverse outcomes? And so with that, there are two things to keep in mind. One is that, so SARS coronavirus 2, the receptor, ACE receptor, is present on a beta cell of pancreas, among many other cells in the body. So SARS virus directly causes beta cell damage. And this is part of a reason why we see so much of the new onset diabetes and admission hyperglycemia in diabetes with COVID. The other thing is that through interaction with the immune system and the cytokine storm that subsequently happens, that causes a huge amount of insulin resistance and worsening metabolic control. And you all who have taken care of these patients have seen that they are going to be in the ICU and they're going to require 30, 40 units of insulin an hour. That is because of this worsening insulin resistance. So hyperglycemia really conveys a significant risk because, among other things, it makes inflammation worse. It's a prothrombotic state. And that when that is combined with known risk factors such as obesity and older age and cardiovascular comorbidities and renal disease, that all leads to poor outcomes. So then there was a lot of kind of a hullabaloo about ACEs and ARBs, and should we be stopping ACEs and ARBs when people are admitted to the hospital, and are they conveying the risk for worse outcomes? And the theory stemmed from the fact that ACE2 receptor is a place of a virus entry into the cell, and people with diabetes do have a higher expression of ACE2, and is that a reason for progression to severe illness? However, there are multiple publications that have been published since then, including overall 9,000 patients experience showing that patients with diabetes admitted on ACE and ARBs do not have worse outcomes. And there is a recent paper that just came last week in Annals of Internal Medicine showing the same thing. So no, we should not be stopping ACEs and ARBs unless there are different reasons. So then the next question is, does A1C at admission matter? Does that convey a risk of worse outcomes? So when you admit somebody, their A1C is 9 versus 7, is the person with the A1C of 9 going to do worse? And there are 2 major studies that have looked at that. One is a Coronado study that was done in France, and this was more than 1,300 patients that were followed. And another study just published now by Agarwal in Diabetes Care, and they have looked to see if there is a worsening of the risk of adverse outcomes across the spectrum of A1C, from reasonable is around 8 to going up, and there was really no increased risk. One thing that has been repeatedly shown to increase the risk of worse outcome is BMI. So both in a French study and in the Agarwal study, across the spectrum of BMI, the odds ratio for complications and worse outcomes clearly went up. And this followed pretty much even the age span starting from 20s to those in the 80s. The difference in risk increase across BMI persisted. And one thing that we also have seen across all the studies that in males had worse outcomes. So what is it about obesity that makes people at such higher risk? I mean, there are multiple risk factors, probably restrictive lung disease, issues with ventilation, prothrombotic state, pro-inflammatory state, and those kinds of things. So that doesn't mean that we shouldn't tell our patients to control their diabetes well, of course, during the COVID crisis. And here are some sobering thoughts. Does the glucose on admission matter? And this is a study that looked at 270 patients with COVID and has shown that this is looking at survival across the spectrum of admission glucose. So in green, you see patients' survival, pretty good in patients with normal glycemia, worsening of survival with patients with diabetes. But here is something that's really important to keep in mind. The worst survival was for patients who don't have history of diabetes, but have hyperglycemia at the time of admission to the hospital. And I want to say that this is not anything new. This has been shown consistently in many studies done by Krinsley from Mayo Clinic have shown that patients who don't have diabetes and are admitted in hyperglycemic, in the ICU, across the spectrum of medical and surgical issues have worse outcomes. However, I mean, it's really hard to translate that. And, you know, if you really ask me, like, do I get excited if you have a patient, like if I get admitted and I have a sugar of 156, is anybody going to even notice that? Probably not. And yet it conveys a worse outcome. And finally, can something be done about it? Patients with COVID have so much going on, and I know that you guys are busy, and I don't even know how can anybody keep up with everything that's happening and changing. So, you know, do we care about blood sugar? And so does the control of the blood sugar in a hospital matter? And I want to just show you results of briefly 2 studies. This is a retrospective chart review from China, and this is in more than 5,000-6,000 patients altogether. And it has shown survival with people with well-controlled blood glucose at 98.9%. And yet, and yet those who have poorly controlled blood glucose, their mortality was substantially higher and the death rate was 11%. I mean, that's a really high death rate. This is another study that just got published in Diabetes Care in October that looked at survival, again, looking at glycemic control during the hospital setting. Survival of those with no hypoglycemia is in blue. You can see they fare fairly well, and pretty dismal for patients with hyperglycemia. So if this doesn't make a case, this difference to control blood sugars as tightly as we can, I mean, I'm really hoping this is a call to action. And the difference here is looking at patients with no diabetes and diabetes. This is an interesting one. It showed the difference in survival with the early insulin infusion to be substantially better looking at patients who didn't have insulin infusion. And finally here, it shows again the same time, the same story, that patients with hyperglycemia but no diabetes in the purple line have the worst outcome of them all, and certainly worse than the green is patients with diabetes who don't have hyperglycemia. So the case is being made that we really, really need to pay attention to the degree of blood sugar control. And so then question 8 is, how should patients be treated in a hospital? And I would like to just kind of make you aware of, there's so many resources. I don't know how can anybody keep up and read it. So I have listed it here for those that are interested. This is a paper that is done by our Endocrine Society, our inpatient group. We published in JCM, just sort of like how to do manual. This is all expert opinion. We don't have randomized controlled trials for any of this. This paper here talks about introduction and changes of how we practice through virtual care, because we do a lot of telemedicine, both for outpatient but also inpatient. There is even international consensus how to treat patients with diabetes. And this website, if you're interested, I'm hoping actually to browse with the group later to just show you what it has. This is called covidindiabetes.org. And it's a repository not only of pertinent papers, but this is sort of no theory. This is just kind of like a primer how to treat diabetes, and has a lot of interesting resources. So in terms of insulin use, there really isn't anything here in this table that I want to tell you that's different than any other patient. The principle of basal, preannual, and correction insulin is still there, but we have to keep in mind that how we treat patients and the protocols that we choose, they have to allow for minimizing the time of personnel with patient, minimizing the PPE use at some point, and really avoiding unnecessary care. So when we're taking care of these patients, these are the things that we want to keep in mind. And I can speak a whole lot more later if anybody's interested in how to, for instance, treat patients on tube feeds. But I do want to remind you that instead of doing protocols like MPH every 8 hours and Novolog every 4 hours, which by the way is 9 injections a day, you could use something simpler like 70-30 every 8 hours, which would be 3 injections a day, and a whole lot simpler thing to do. And there are well-established protocols that can guide you through all of that. But I also want to remind you that for patients who are not requiring a lot of insulin. So these are not necessarily your ICU patients. They're more going to be a floor, a little bit more stable patients with diabetes and COVID, that use of DPP-4 inhibitor in combination with basal insulin and a correction scale may actually work. Now, that is not going to work for patients that are needing more than 0.6 units of insulin per kilo a day. So, you know, if a patient comes and they're on 100 units of insulin a day total, let's say 30 of Glargine and 30 of Novolog with meals or something like that, that's not going to work. But for those that are not requiring a lot of insulin, use of DPP-4, as outlined in this paper, has been shown to work. There is extensive experience with the use of DPP-4 inhibitor in combination with a low-dose basal insulin in non-COVID patients. And so for those that are of you that are interested, the protocol is outlined here. You've got to keep in mind that depending on which DPP-4 inhibitor you may have on your formulary, you may or may not have to adjust it for renal failure. But it is certainly something that can be considered. In addition, for institutions that cannot give insulin drip on the floor, and a lot of patients with COVID-19 and diabetes coming with DKA, I do want to make everybody aware that sub-Q insulin protocol for treatment of DKA have been published. And validated, and this is the most recent review from Nadine Palermo from Mass General that goes over utilizing sub-Q insulin for treatment of DKA. It cannot be used for severe DKA. It is only for mild to moderate one. But most protocols, without reading the small print, are about Lispro, about 0.2 units per kilo, administered every 2 hours, in addition to other aspects of DKA management, work pretty well. I want to also alert you that early addition of glargine, basal glargine insulin, together with a sub-Q Lispro every 2 hours can prevent rebound hyperglycemia and a rebound DKA. So again, this paper has all the protocols outlined in detail. And finally, last question, CGM. How about use of continuous glucose monitor? You know, these people are very brittle, and this is a topic that's near dear to my heart, but also that causes a lot of frustration, because I want to remind you that the continuous glucose sensors do not have the FDA approval. However, FDA in April has sent out sort of like a no objection letter, you know, so that's kind of like, will like look like this through and let people use continuous glucose sensors. There is a major CGM consensus guideline just published by Galindo and his group in Journal of Diabetes Science and Technology, like hot off the press, and I can share it with anybody that's interested. And also another very practical paper talking about implementation of CGM, like how do you do it? Because you can't just like give people CGM, like you have to figure out who's going to place it, you know, kind of like who's going to bell the cat, right? So who's going to put it on the patient? Who's going to monitor the readings? What are we going to do with alerts? How is IT going to handle it? So it's not simple. However, it not only can it be done, but certainly the consensus guideline, and this is a worldwide consensus guidance that was issued encouraging a use of CGM. It's not easy working with hospital administration to make this happen, and we can talk about details how it can happen. It's not easy to work with the IT, but they have been shown to help. And specifically, you know, if you think about what is the clinical considerations, what are the CGM indications for those patients who are on steroid-induced hyperglycemia, certainly those with type 1, who are very brittle on multiple injections, it may make your care easier. I can tell you there is a recent randomized controlled trial that was published looking at the use of CGM for prevention and treatment of hypoglycemia with embedded protocol for hypoglycemia action that has shown substantial improvement in outcomes. So I think that that's something that you will be hearing more about, and hopefully most of us can adopt. So in conclusion, diabetes doesn't increase the likelihood of infection with coronavirus, but once people get it, it's associated with higher complications, and glucose control is important and may improve the outcomes. So that's my 10 plus minutes.
Angela, thank you so much. Gosh,
Thank you.
I just got a whole course. No, seriously, it was like a great overview with some really helpful detail as well. So there are a number of questions in the chat and in the QA. I want to ask one of those and then turn it over to either Dr. Marcozzi or Dr. Jolly if they have any questions or comments. So I'm going to start with one, then turn it over to them if they have questions, comments, and then go back to the what I see in the QA and chat. So the question that I saw in the QA, is there a specific cutoff level of hyperglycemia that marks worsened survival? Is it an acute level or an A1C that is a marker?
So A1C, as I've shown you, is not really a marker. And however, hyperglycemia, anything starting above 180 is a marker of worse survival. And again, specifically in patients with no diabetes, if you take anything away, please keep that in mind.
Hey, thank you. Okay, so Dr. Marcozzi or Dr. Jolly, questions, comments before I move on to others?
It's Marcozzi, outstanding presentation. I'll turn it over to Till.
Thank you.
Yeah, great presentation. I mean, that was, kind of a rapid review of all we need to know about this. One of the questions in the chat relates to the relative inclusion of other things like renal insufficiency or hypertension or other things, and how independent is diabetes and hyperglycemia relative to those? A complex question that you may not have a.
Yeah, I'm not aware of studies, I mean, that would exclude comorbidities just because diabetes is always associated with it, right? However, if we look, and especially BMI is such a profoundly important risk factor. But if we go back and look at the data on type 1 and increased mortality with type 1 patients with and COVID, once they are admitted to the hospital, again, they're not more likely to be admitted, but once admitted, they fare worse. There is and we think it's so much of this is DKA actually for type 1, because that's a huge issue in type 1 and COVID is DKA. So I would think that confounding factors of obesity and other comorbidities are probably the most important thing. But remember, diabetes is a pro-inflammatory state. Diabetes itself is prothrombotic state, you know, so I guess I can't quite answer the question. I think it's all of the above.
Yeah, that's what I expected. And a good point about the pro-inflammatory and the thrombotic things, which I think people don't think about as much, but
Yeah.
really related to this illness.
Mm-hmm.
Sorry, I had to figure out where the mute button was. Imagine that. So, so Angela, there's a question about whether or not the hyperglycemia at admission is a modifiable factor in the pathway course of illness, or merely an indicator of the more advanced disease the person has at admission, who then will go on to more severe illness.
Correct. It's a chicken or the egg question. I would think that hyperglycemia at admission is a marker of disease. Absolutely. And I think the reason to support it is the fact that patients with no history of diabetes and with hyperglycemia on admission do so poorly. So I think it's a marker of disease. I think it's really fair to say. However, I think what more should capture our interest is the fact that glycemic control during the hospital was shown to matter.
Yeah, thank you. And then again, I'm getting like a little bit of sensory overload with the questions. Wow, there's a lot there. And we're not going to be able to answer all of them. Let me see what we can do to get to some of this. Do you suggest insulin pump patients to suspend their pumps while an inpatient?
Great question. Okay, so we are a huge advocates for people to use their pumps in a hospital setting as long as they're able to do that. There are many reasons, actually. So I'm quite familiar with the data. There is no data showing superiority of glucose control with pumps versus basal bolus. However, there is a greater sense of patient satisfaction, and that's important. So better therapeutic relationship and greater sense of control. So we absolutely advocate for people who can use the pumps to continue using them, providing there is hospital resources. So it's not just about like, you have to make sure the patient actually knows how to use the pump. And then I don't know if you guys are aware, like there is a specific a contract that you need to sign with patient where they understand that using pump is a privilege. This is not their right. And that they need to be evaluated by diabetes educator. Do they know the buttons? Do they know how to change the rates, right? And then they need to allow the nursing staff to be able to write it down, and they need to allow physicians to manage. So for those of you that are interested, this has all been well kind of outlined, and actually even in the latest paper that I mentioned about CGM consensus guide, that also offers a pump contract for those of you that are interested.
Thanks, Angela. And before I forget this question, because it's like my question, there's a lot of others out there, but this one, and it's because Dr. Jolly and I work on the healthcare resilience work group and co-lead the telemedicine team, and would be interested to hear your thoughts on how telemedicine specifically has impacted that dynamic of COVID and your patients that you follow, or it's just the same, only more, or are there some specifics about it that have been helpful or maybe detrimental? So
you're talking about outpatient as well, or inpatient?
Yes, outpatient, actually outpatient more than I was thinking about.
So I'll tell you what, this whole thing has been absolutely amazing. So my first thought on telemedicine, when it works, it's better than sliced bread. And when it doesn't work, I want to drink at 8 o'clock in the morning, right? I mean, sort of, I have been amazed at positive outlook of patients with across the spectrum of their diseases. So what I do for a living is I do a lot of inpatient stuff, inpatient diabetes. I also do a lot of pump and sensor type 1 youngsters care. And also I do pituitary tumors. So a lot of my practice is pituitary tumors. I cannot tell you how much patients love the opportunity to share the screen, to show them their MRIs, to take them through images, to discuss labs. They almost pay more attention because they're not distracted by the environment of hospital setting. The other thing in terms of connection, specifically for patients with diabetes, to be able to see them in their own environment, to be able to see the pets that they have at home, the spouses, people are showing me their like honey-do list projects, like the porches that they've built. It's such a source of pride and joy. And I'm kind of touchy-feely. I feel that these personal relationships are so important, and getting to know patients on a personal level was actually, I think, enhanced by telemedicine, contrary to what most people thought. And the pain in the neck, is not all rosy. Integration of the technology, so our ability to download the pump and sensor data and integrate it into electronic medical record has just been a sore spot. I have found a workarounds, and I have actually, as a medical director, I do have a little bit of a people hear me when I think we should do something as a clinic. So we did figure out how to integrate this into EMR, and I can share with people who are interested. Just because that's not easy. But other than that, I think it's been great.
Yeah, you sort of like alluded to a whole new chapter in how to take a social history chapter of the physical diagnosis book. Yeah. So another question, are more non-insulin dependent diabetics placed on an insulin protocol while hospitalized since COVID-19?
Yes, because COVID-19 causes so much hyperglycemia. And as I mentioned in slides, it's not only the insulin resistance because of cytokine storm. Remember, there is a ACE2 receptor on the immune cells, right? And the dysregulation unleashes the cytokine storm. That by itself causes insulin resistance because it breaks the insulin signaling pathway on multiple levels. That's one thing. And the other thing is the beta cell damage. Absolutely. There is more diabetes. There's more insulin resistance. People need a lot of insulin. No question about it. The reason why I wanted to share the data on the DPP-4 is because I want people to be aware of, and I'm honored to be a part of the Endocrine Society Writing Committee, which will be coming up with a hyperglycemia guidelines. I want to make people aware because it's easy to say, yeah, put them on basal bolus, but that's like 5 shots a day. That's a lot of nursing work. That's a lot of anxiety for providers who don't know how to order it. I mean, how many people are comfortable with a weight-based regimen? So there is a role for non-severely resistant people that can be well controlled with glargine or whatever basal insulin you have in a DPP-4 inhibitor, not in the ICU.
Thanks. I've got 2 more, and then we're going to go to the polling. How do you, boy, this is what I actually would have asked. Great question. How do you control the hyperglycemia brought on by the widespread use of steroids for COVID?
Yeah. Okay. So we deal with this all the time, and then they put them on tube feeds, and then they put them on TPN. So we can talk about that. It is not easy. Couple of things about hyperglycemia and steroids to keep in mind are the following. Prednisone has a pretty predictable effect on blood sugar if prednisone is being used. If you give it in the morning in patients who are eating, there will be a progressive hyperglycemia with every meal, and then sugars overnight won't be as high. So the first rule is to know, do not over basal the people. Don't give them too much basal insulin because they will invariably get low. Second, hyperglycemia with steroids is mostly postprandial. So people that are not eating well, even on high doses of steroids, if they're NPO, you won't see such a high blood sugar as you will. Once they're better, they look at carbs and sugars go up. So for patients who are on prednisone, dose of MPH in the morning to go with a prednisone dose and the meals actually may help control them pretty well. The distribution of basal bolus insulin that we usually talk about, that should be in about 50-50 in people who eat normal diet, for steroids is about 30-70. 30% of total daily requirement on steroids is basal insulin, 70% is prandial. So be ready to really be more aggressive with their nutritional insulin. That's one thing. The other thing is dexamethasone has a much longer duration of action, doesn't have the same peak the way prednisone does, because prednisone will cause the blood sugar to peak at about 5-6 p.m. Dexamethasone doesn't have that peak. So you can control people with, I love to do rapid acting insulin with meals, and then also give them correction at bedtime and 3 a.m. so that I don't have to be over aggressive with my basal insulin. Because if you run during the daytime and you see super high blood sugar and you get carried away and you just increase their glargine, you can really cause trouble.
Thanks. As I think I may have mentioned to you, Angela, when we were communicating by email, we have a really broad range of participants, and this one comes from a rural EMS provider. Do we know how soon we need to get their glucose under control? I work in rural EMS. Should I start lowering hyperglycemia prior to actually arriving at the hospital, which might be an hour away? Increasingly, we have patients who already know they are COVID positive.
Yeah, so as we have shown, A1C doesn't matter as much, but the sugar and admission does. But again, the chicken or the egg question, I mean, I will not belabor on that one because that's a fair issue. I'd say choose your priorities, do what's feasible and also what's safe. So if you can control them well prior to hospital safely, great. But is that really possible for most patients? Certainly for those with type 1 who know sort of what they're doing, I think that may be possible. Keep in mind, hypoglycemia is bad. So you don't want to risk hypoglycemia. So I would say they'll come to the hospital. You got plenty of days to get them well controlled. If you're asking me about the time of control, the only data I can give you is from actually cardiothoracic, so not COVID data. In a cardiothoracic surgical setting, I don't know if any of you remember all data by Portland Protocol and Fornari. First 3 days matter with a CT surgery.
Thanks. And I have one last question, and then Echo, we'll go to the polls next. We had a question from a rural EMS provider. Obviously, many of the questions are from physicians, many intensivists by the nature of their questions, I think, interns. For the emergency physicians, and I would count myself as one of those, realizing that patients may stay a long time in the ED before they get to a unit or to the floor. Is there something you would say to the ED docs who are participating on this particular rounds that, like, you know, guys and gals, I wish you were doing this for these patients with COVID-19 and diabetes?
I think utilizing correction, if you have correction scales in your institution that are in place, I would not shy away from using those, at least so people are not super hyperglycemic. You know, it's easy for me to say, oh yeah, put them on an insulin drip, but I mean, I understand that it may not be feasible. So again, we have to stay here realistic and see what we can do. Keep in mind that correction scales have been validated, and also keep in mind that they account for different sensitivity of people. So those level 1, 2, or 3, if anybody needs resources, I would be happy to share with you. You can't really go wrong if you at least start with that. The other is a weight-based dosing of insulin. It's phenomenal. Keep in mind, weight-based dosing of insulin, 0.3 units per kilo total daily dose for elderly, bad kidney function, type 1 diabetes, ranging to 0.6 units per kilo total daily dose of insulin for those with type 2, insulin resistant, and obese. So don't be scared of the concept to give people insulin according to the weight. If you don't know where to start, that's always a good start.
Thanks very much, Angela. What a wealth of information, much appreciated. I'm going to do the polls, and this time it's a little bit different. Before you put the poll up, let me give a little bit of background. as I mentioned previously on the rounds, I wish we could have like stopped these rounds about 6 months ago and the virus would have like disappeared seriously. And I know we all would wish that, but that's not the case. And after doing 80, I think 84 of these, counting this one, I think it's 84, 85, lost count, but with over 35,000 participants, it's time to do a pulse check on the so what question. Are they actually helping and being supportive of both patient care and clinical operations? So these poll questions, there's only 4 of them. Okay, so if you can hang on till the 1 o'clock meeting, I'd be most appreciative. After we do the poll, then Angela gets the last word, as we always have the last word from our speaker. There are 2 quantitative polls and then 2 qualitative polls. I think we're going to do the quantitative ones first. They're straightforward to the point, and then I'm going to turn it over to Amanda to like walk through how we do the qualitative ones, which require some typed in responses rather than the single choice piece. So Echo, if you could put up the first question, and before you respond, let me walk through it, if you could. The first one is, in the event of a future national or local emergency, would you join Echo calls again? And it's straightforward Likert scale. So go ahead and respond to that if you would. And as you know, the faster we get the responses, the faster we can move on to the next one. You can get to the 1 o'clock meeting. Amanda, if you can like help me know when there's a critical mass of respondents so I can move to the next one, because I'm having a hard time seeing that on here. There they are. Okay, yeah. Yeah, we'll just wait for some response. The other thing I need to say is these are not, I don't go into we don't go into identifying who responds how. They're de-identified, okay?
Also, Rick, it's Bruce. Just want to remind everyone, we're using a different polling platform, Poll Everywhere. Just click on that link in the chat that Amanda shared right before the poll went up. So go into the chat, click on that link. It'll take you to a browser where you'll be able to answer these questions directly.
Thanks, Bruce. I know this is new for you and it's new for us too. So, but it's all new, as Angela's pointed out. It's all new. Yeah, part of the whole polling platform issue is to try to get the qualitative information. So just be patient with us. We'll do another like minute or so, and then we'll move on to the next one. Now we got the hang of this one and make the others easier, I hope. I'm seeing like 57 of you have responded, which is really helpful. All right, another 5 seconds. We'll move to the next one. All right, let's go to the next one. And you saw the results just like I did. Thank you. Yeah, there have been about 150 participants on this particular call over the past week or so. Well, a couple of weeks. We've ranged from hundreds to 300, somewhere in between there, for all the calls, for each of the calls. Do you believe that information provided by Echo calls has helped you provide better care to your patients? Yeah, much faster. Second one, that's for sure. Angela, while these poll responses, you don't get a chance and I don't get a chance to respond to them, but if you see things that you can easily respond to in the chat or QA, feel free to
Yes,
do
I
that.
can look, totally, yeah.
Yeah, thanks. And we have 58 of you have responded. I'll wait another 10 seconds. All right, let's stop there. 59 have responded. Thank you. And leave it up there for a second. Well, it was 68% said yes, and then 30 something or said strongly agree, then 30 something said agree. So now this question, okay, this is like the type in thing, okay? So let me give a background before you start typing. What specific clinical practices have you changed or implemented as a result of COVID-19 clinical rounds training? That means since March 24th, okay? It doesn't mean just today's, it means over the period of time since we started rounds and the ones that you, obviously the ones that you participated in, or maybe you heard in the hallway, they talked about it on the rounds. Actually, when I saw this, we did this polling yesterday for the first time with the EMS, and watching these responses come up is actually it's fascinating to watch. Proning, I couldn't believe it at first. The responses, it's pretty fascinating to see the responses that go back. I mean, some of the topics that we've done, people obviously are recalling some from quite some time ago. Angela, obviously from some of these responses, I think you've done us really well.
Oh, that's cool, because I'm focused on the questions.
Yeah, no, I get it. But yeah, sorry. Yeah, it's that multitask thing, guys.
And to all of you, I am so appreciative of wonderful comments. So thank you so much.
Yeah, I mean, and actually, Angela, you're the first one that I recall, and Bruce Lee, you might remember one, but I just don't, that did that 10 QA format that I mean, it was like, I looked at your slides at the beginning, it's like, oh my gosh, I'm going to be going into diabetes rounds for like 4 days and the 3-volume set. But then the way that you framed it with a QA thing was just magical. So thank you.
Thank you. I have no clue how come I came up with that. It's one of those things that come to you. Thank you.
Well, it was a really good one. We'll leave this up for another 20 seconds or so. I really appreciate seeing these responses. All right, 40 of 130 have responded, 41. All right, let's stop there. 42 out of 120. That's a lot of responses, actually. Thank you so much. Helmet ventilation being the last one coming in. Oh, not a clinician. All right, let's stop there and we'll move over to the next question. And again, it's based on all 84 clinical rounds, not just today's. What specific operational practices have you changed or implemented? Operational practices. When we started the rounds, they were all around patient care and operations. Then we got more focused as time went on, and now sort of going back to the future with the surge of patients being a little bit broader, but yeah. While people are inputting a number of responses in here, just sort of a follow-up. No, it is a specific follow-up to rounds that we did. We did a special session last week that combined home health, emergency department, EMS, and critical care. And, you know, like what happens after these rounds. And it's been fascinating to watch how there's been a great dialogue among the panelists and leaders from home health and EMS around their connectivity. So it's one of those unintended surprising consequences that actually may have a really good positive outcome. So one of the things that I think has actually worked out in ways that I don't think anybody would have predicted, the ability to cross disciplines and sectors of the healthcare and cross sectors among healthcare has been really very gratifying to see some of the connectivity that's happened. I'll wait like another 15 seconds, then stop. I'll make a brief comment and then turn it over to Angela for a final comment. All right, we had 25 responses, and I realize we're at the top of the hour, so let's stop there. As I mentioned, you know, we've done 84, 85 of these, and 35,000 participants, and realizing we have like not that many on any one of the individual rounds compared to 35,000. So next week, we hope to send out an email to all rounds participants. If you've already responded here, then you don't need to respond to that email. But if you were unable to respond, please respond. We're going to ask the same questions in an email, but felt it was really important to make sure those participating on rounds this week had the opportunity to do this in real time. So Bruce, anything else to say on that about the polling before I move to Angela? All right. Thank you for all of you participating. Yes, it's a new way of polling, and it's not the same and hard to adjust and so forth, so on, and really appreciate bearing with it. Angela, final comment, or you could ask us all questions, but yeah, I believe you've got the expertise to answer the diabetes thing. So
No, I do. Like, how do you keep updated? You see the pile of stuff that I haven't gotten to yet. No, thank you so much for inviting me and for all your attention. Here, we're just sharing this website with people.
please do. Yes, please.
So if you Google COVID in diabetes, you're going to see this website, and it's basically a repository of sort of like a cookbook plus science. So check this out. If you click on inpatient diabetes, ICU, non-ICU, how do you treat hyperglycemic crisis? So this is Shivani Agarwal. She does fabulous job in New York. So this is her Montefiore sub-Q DK protocol. So then you click on view and check it out. It's all yours. So that's like one. And so people are sharing protocols. I mean, this has been just like a wonderful show of human goodness, which always kind of gets me optimistic. Look at the hospital CGM implementation. So this is, I don't know if this is just like the CGM for the, oh yeah, this is a really good one. This is the one that I was telling you. This is a how to do CGM in a hospital. So then you have like what to look for, when do you have to check the blood sugar, when to use it, when to not use it, when to take it off, like all of it. And so you have all the clinical considerations. So somebody was asking me about medical nutrition. So you have all kinds of protocols for how to treat medical nutrition. I didn't know this was here. This is my paper in medical nutrition. I'll say it's really good. Check it out. So anyways, feel free to use it, because I really think it's hard. Like, just the fact that the information is available, I don't think that's necessarily helpful, because there is so much stuff available. So, where do you find what you really need? Anyways, I think this is a great website. So you are muted. Rick.
Angela, thank you so much for your presentation. Obviously, by the comments made by participants in the chat and QA, et cetera, you certainly serve the function of like the peer-to-peer educator in a marvelous way, and we're deeply appreciative. To our participants, thanks for hanging in there. Those that are 5 minutes late to your 1 minute meeting, go on rails, whatever, have lunch. Thank you for participating. Expect that email from Echo. Help us out if you didn't participate in the polling, just because we've got to figure out where we are with this. And then to Dr. Jolly and Dr. Marcosi, thanks for joining us today. Really appreciate that. And Echo, as always, marvelous, but really appreciate all the hard work and making sure things run as smoothly as they do after all these rounds. And Angela, thank you so much. Just
You guys
deeply
all.
great.
Okay, bye.
Yeah, thanks. Bye-bye.